Welcome everyone. It's so Welcome everyone. It's so good to see you all here and to welcome you. Thank you very much for your continuous support and for your interest in the news projects and the news webinars. It's really amazing to be together from all over the world at a single platform. And I hope that you all know about the launch of the news membership, which is totally free of cost for everyone to join. And it is there's also a special separate membership option for the medical students. So if you are a medical student or if you know a medical student with special interest in neurosurgery, please feel free to rotate the registration link again. The membership and everything that is being organized or being introduced by the news is free of cost, as you all know. The webinar will start from about like 30 minutes from now, inshallah. But please stay tuned as we might be sharing more updates during the webinar. After the webinar, I will be pleased to share the first project for the news members, and I hope that you will all be so excited to contribute in the project. Again, this project is free of cost, and the goal of news is to promote free and accessible neurosurgical education and training all around the world, and also to encourage and support peers and juniors from all parts of the world. I believe that this activity will also help you boost your CV, and I will try to share as much as possible whatever I have learned from my own experience, and I will also try to, arrange more training workshops and anything which is relevant, anything which might help you in completion of this project. And like I have also mentioned several times before, that do not ever worry that you are doing this thing for the first time, because nobody is perfect when he or she tries to do something for the very first time for which they do not have any experience before. But it is important for us to take the plunge, and that's why I'm here. I'm all the time around to help you out in as many ways as possible. And we can also request some seniors to, jump in and help you in attaining the goals. So the training workshop will be held later this month or earlier next month. And also our book is going to hit stores after, either at the end of this month or early next month. And and there are so many things that, are um, many things that are under process behind the scenes, and I hope you will be we'll be really happy to see once these projects are out. Again, thank you very much for your continuous support. I'm going to share the links to the pre-membership again with all of you, and please feel to join, and please feel free to share it and rotate it among your friends and colleagues. And it is always amazing to have you all here. Another point is, like, in all the previous webinars, I will rotate the quiz link after the end of the lecture. You just have to submit the quiz link to receive your certificate of attendance. And this time I made a few changes in the certificate. It's now an embossed certificate, and obviously there is an ID for the certificate. Okay, so just let's stay tuned, and we will starting in about 35 minutes from now. And please feel free to share your suggestions and your comments. And during the show, please feel free to use the chat box to share your questions. And again, I have also launched the news blogs and the newsletter. And I really wish to invite you all to send your submissions to my email address. I'm sharing it in the chat box. Okay, please feel free to share your submissions on my email address. I will be so happy to upload your blogs and also include you in the newsletter. There is a special medical student edition for those who are medical students. I will be so happy to publish it. So again, I want to tell you that the goal of the news is to promote free accessible neurosurgery and to encourage our friends, our colleagues, our juniors from all around the world. And and again, it's totally a free platform, and you just have to be, I think it's amazing to learn together and to learn from each other and to promote, education and training. So this is the main goal. So do not have any do not shy away from your submissions, or do not shy away from taking part in the projects, because everyone has contribution. And if there is something that in with news, I believe that we are all here to support each other and to make corrections and to improve each other according to experience and everything. So whatever you share, please be confident, share your work and your submissions, because there's always some room for improvement, no matter how senior you might be. So sometimes there is some particular demand which is in someone's mind. So please do not hesitate to send your submissions. Always be very confident whenever you are submitting. This is my advice to you, whether you are submitting to the news or to any other platform or to any other journal or anything. So always, but always have this, have this in mind, that you might have to make a few modifications. These are not corrections, basically these are modifications. You are just trying to make it look appropriate. So again, thank you very, very much. We will be starting shortly in about 20 minutes from now. Inshallah, stay tuned. Again, thanks a lot. I've just received a text message. Of course, older members are more than welcome. There is no age limit here. Okay, so while there is a particular, emphasis on junior neurosurgeons, and this is only because, it is just to make sure that the juniors are joining and they are taking part, because many juniors, they do not take part or they hesitate, like I have mentioned before. So this is basically, whenever I say juniors, it's like, okay, I'm trying to emphasize the fact, taking it into account that most of my attendees and members are supposed to be seniors. So obviously, older members and seniors are like more than welcome, and I think they are assets. They are our assets. So I believe that no matter at which stage you are in your career, please feel free to be the member of news, and feel free to contribute as much as possible for the news projects, because what I really wish is to have you all at a single platform, and from all over the world. And this is why I open news, and that's what I'm doing. I'm trying to promote as much as possible, all this neurosurgical education and training all over the world. So whatever is your experience level, whatever level of career you are in, please feel free to join and to contribute as much as possible. So if you are an older member, you are more than welcome to participate, and I will be so happy to have you contribute in the projects for news. And there's just one thing that I want to mention, with that whenever you send a text message, kindly mention your name and give me a little introduction, so that I can save you and have an idea of who you are. Um, yeah, obviously, because this is an older member of news. Yeah, okay. Yeah, obviously, because when you join news, haven't this mode of, certification back then. This is what I've recently introduced, because I believe there should be some sort of, a membership card or something you have to show, and you have to, something to hold on to. Okay. So yes, please, I will certainly recommend you, if you have been following news for since the very start, please do submit the membership form and get your certificate. Sometimes it takes a little while. I have a very overwhelming response for which I'm really grateful to all of you. And after that overwhelming response, the quiz was, the form was automatically closed because the number of responses exceeded the limit where Google allows one to, submit. So I manually had to open the submissions. Whenever there's an issue, please feel free to notify me if there is any issue regarding submissions and etc. So please feel free to submit the Google Forms again. Thank you very much. Hello, everyone. Thank you very much for joining the news webinar today. We will be starting in about 17 minutes from now. Soon, Professor Pascal Jabbour joins us. Thank you very much for your continued support and for your interest in the news webinar series and all the news projects. And I hope that all of you have received the membership link. Please feel free to join. And again, I want to promote everyone, and no matter at which stage of career you are in, there is always a special emphasis on the new members as junior neurosurgeons. I'm a young neurosurgeon myself, and this really means a lot. And especially, the women neurosurgeon, it means a lot to promote them, to support them, and to encourage them. And that's what I have felt throughout my own career, that all the young neurosurgeons and women neurosurgeons need a lot of support. This is why that's why I created News Network, and I'm trying hard to make it as much useful and beneficial for all of you. I again really wish to thank you all for your content support and work. And again, I will be, making an announcement of the first members only project. And I really want to ask you, to request you to take part. And again, please do not hesitate to participate in any of the projects of the news, because the projects are meant to, train you, to support you, to, encourage you, and to have a boost in your CV. So these projects are like, I myself assume that everyone has, has the potential to improve, has potential to work more. We are all learning together. We are all learning each day. So please do not hesitate to send your submissions and contribute in the projects. Don't have this type of thing. No, this has to be perfect. No, nobody is perfect. Especially if you haven't done these things before, do it now. Okay, because you have to start. If we keep on thinking that no, I have got no idea, you are not going to make a difference later. So you have to do it now. I'm encouraging you, do not hesitate to send it, because you always have some space to improve, some say to modify. So please send your submission as much as possible. And again, I want to tell you that everything that is being introduced and organized by news is totally free of cost, just to promote and encourage our our peers and our juniors. Okay, and if you are a medical student, there is a separate form for medical students as you know, as a member, and you are all our very worthy members, and you are also beneficial. And I'm personally looking forward to your submissions, and please do send your submissions for the news blogs and for the newsletter. And again, looking forward to have you all. Thank you very much for joining today. We'll be starting in about 15 minutes from now. Professor Pascal, I can see you. Thank you very much for joining today. Hi, sir.
Hello.
Hello, sir. Thank you very, very much for
Ah, I
joining
can't hear
today.
you. Okay, I can hear you now. Yeah, hi, how are you?
I'm doing great, sir. Thank you very, very much. I hope you are doing well. Thank you very, very much for joining today.
Sure, my pleasure.
No, pleasure and honor it is all mine and is all ours, sir. Thank you very much, sir. Sir, I'm just waiting for the link
Yeah.
replay to see the wonderful case you have presented us today.
Ah, the SNIS.
The link to 2024, case. The live case on, the
Ah, the
multiple
live
and
the live case I've done for Link Paris. Yeah, yeah, yeah.
yes, exactly,
Yeah,
doing Paris. Unfortunately, I wasn't able to attend it, so I'm just waiting for the replay to see the multiple
yeah,
carotid aneurysms. That's
yeah,
what
yeah,
I read
yeah.
about.
Yes, yes, yes.
So you always share amazing things, so much wonderful learning and insightful cases. Are they? So I'm a big fan of yours. So
Thank
thank you
you.
very much
Now
for joining. For,
what's you're a neurosurgeon, right?
yes, I'm a neurosurgeon with special interest in
Do you do
neurointerventions.
endovascular?
So yes, we do. Here we have what is Angel Suite in Pakistan. I'm actually being trained at PINS, Punjab Institute of Neurosciences, which is the largest dedicated center for neurosurgery and neurointervention in Pakistan. It's a public sector hospital. So we did have the neuro Angel Suite. I always had a special interest in it. So recently I've done the ETSI as well as in my additional qualification. It was so great because I've been in touch with Esmint and it
Hmm?
was an apnea exam back then. I had was very special interest in this myself. It's something new. So.
Oh, great. How long have you been doing those webinars?
So actually, I've been initially I started about in I think it was in 2021, and first started with the WFNS Education Committee. And Professor Louis Borb actually asked me to create a special platform for residents and medical students. And later on, I became an executive board member of the AANS CNS Joint Section for Tumors, and also the ISPN. And then I later started this platform called the Neurosurgery Enthusiastic Women Society. It's open for both men and women. Basically, just to denote and highlight the rather underrepresented groups. Many of my female colleagues wanted me to start something that, to make them some sort of, to give them
Right.
a name or to highlight their. So that's why I called it. So
Well, you're doing a fantastic job.
really, sir, it means so much to me. Coming from you, it means a lot to me. Thank you very, very much, sir.
Absolutely.
Uh, Thank you so much, sir. Sir, would you like to check your screen?
Yeah.
Because I know you have a very busy schedule today. So I believe that if you want, you can start now because attendees will come joining in. This is also being broadcast live on neurosurgical.tv and on my YouTube channel. So many of the attendees are on neurosurgical.tv and on my YouTube channel as well. So I hope, sir, as I know that you have a very busy schedule, and I'm really, again, really deeply grateful to you for the time. So I
Yeah.
believe if
You know
you
that that's okay. I mean, we can start on time. I don't mind. We can wait a little bit.
we just have 6 minutes. I really wish to say just a few lines of your introduction, or hopefully, actually, you don't need any introduction, but for the sake of for
Thank you.
a formality, sir, would you like me to say just a few lines of your kind introduction?
Yeah, sure.
Thank you
Thanks.
very much, sir. Again, it's a matter of great honor to welcome Professor Pascal Jabbour today. And as I have mentioned, he doesn't need an introduction. And personally, I'm a huge fan. He's a huge inspiration for me, and I believe for all of you, especially the young ones, and of the young neurosurgeons, especially who are involved in endovascular procedures. So, but I will certainly have the honor of stating a few lines of introduction for Professor Pascal. Jabbour, and he's a professor of neurological surgery and the head of division of neurovascular and endovascular surgery and neurosurgery in the Department of Neurological Surgery at the Sidney Kimmel Medical College at the Thomas Jefferson University. He's a dually trained vascular neurosurgeon, and like you obviously know that he can perform both endovascular and open conventional surgical procedures. And he's also considered the pioneer of trans radial approach, and also introduced the robotics and neurointervention, which is, quite a very futuristic, very an important point, especially after the pandemic. It has become very something of great interest and all the rage over there. And he also pioneered several techniques, and a new technique especially for the treatment of Rett syndrome and babies. And Professor Jabbour has received a national award for pioneering this new technique. And he's obviously he has written about 360 papers. He has presented amazing cases at all the top conferences. And most of us who have been to such conferences have the privilege of listening to his lectures and to listening to his references. He has authored three comprehensive textbooks, and there's a lot of, he's like an author that you really wish to cite, really wish to go through. And I'm always looking forward to all the work that he publishes each day. So, again, thank you very, very, very much, sir, for giving us time, for sparing time from I know your extremely busy schedule, and it's an honor to have you. I'm so overwhelmed with joy to welcome you today, sir. Sir, the floor is all yours. Thank you very much for joining us.
Well, thank you very much. It's a pleasure and honor. Thank you for having me, and thank you for the nice introduction. So I'm gonna be talking about some advances in treatment of brain aneurysms. Those are my disclosures. This is the Thomas Jefferson School of Medical School, and this is the unique model. This is a subspecialty hospital. This is where we do all our neuroendovascular and open vascular work. So it's just in one subspecialty hospital, and the main Jefferson Hospital is a couple of blocks away, where all the rest of the specialties are done. So this is really let us do a lot of things, because we don't have to share any infrastructure with any other specialty or subspecialty. This is just a neurovascular hospital. Philadelphia is known for the Philly cheesesteak, and those are the two places that compete all the time, Pats and Geno's. When you come to Philly, people would ask you, "Are you a Geno's or are you a Pats?" And you see the cheese here in the sandwich each time I'm doing an endarterectomy and removing a plaque. You know, it reminds me of the cheese in the sandwich. That's why maybe we have so many carotid disease. And then it's also the city of Rocky Balboa. Those are the Rocky Steps, and this is the Museum of Art uh, that I'm sure everyone has seen the movies. So practically, this summarize everything I'm going to talk about in the coming 45 minutes. As you know, there are multiple ways of treating the disease, and we're lucky to be living in this day and age where we have so many tools to fight the disease. And if everyone agrees on the slide that, that's it, I already sent my message here that it's not about the tool, it's about the disease and all the tools available to fight the disease. Evolution's gonna happen regardless if you like it or not. So it's up to you. You can adopt and embrace evolution, or you can just stay where you have been practicing for the last 10 or 20 years. Even Homer evoluted. And the tools evoluted, as you see, from surgery to the most recent intrasaccular devices. And again, it's not a competition of tools. We should look at it as it's all the tools against the disease. Disruptive innovation, and this is the world we live in. Disruptive innovation is a word that was used by a business school professor at Harvard, where he described the process by which a product emerges into an existing market, typically from outside established market leaders, and then relentlessly displaces established competitors. And imagine how many times we see it nowadays, this disruptive innovation in everything, and in neurosurgery and in neurovascular. Every day there's a new tool, new technique, a new device. And it's really our job to make sure that the evolution of neurosurgery remains disease oriented and not procedure oriented. We are here to treat the disease, not to use a tool. And then we should stop advertising for a tool. So there are so many choices nowadays, right? It's like a little kid going to a candy store. You go, you have an aneurysm. There are so many choices. Sometimes it can be confusing. The first disruptive innovator was the flow diverter, the pipeline. And this is an aneurysm without a pipeline. You see the contrast going in and out. And this is, we call it the coefficient of washout. That is here very steep, and here it's like less steep. And you see what the flow diverter does to the blood in the aneurysm, the waving of contrast, the stasis, and then the thrombosis and reconstruction of the blood vessel, of the parent vessel. This is the first time we treated the source of the disease and not the disease itself. This was the first time endovascularly where we looked at the parent vessel and we said, if we are able to heal the parent vessel, that's our goal. We will be able to take care of the aneurysm, as compared to going in and treating the disease itself, like coiling an aneurysm, but ignoring the initial disease of the parent vessel. So this was a paradigm shift when the flow diversion was introduced. This is, for example, a FredX device that I used on an aneurysm at the neck. And see, those are nice, beautiful devices where you can see them, you can see the tines of the stent and everything when you do an expert CT. There are now with the surface modification, this is the new generation of flow diverter. For example, if Fred used to be Fred, now it's FredX. And because of the PMEAX technology that they added to the surface, mainly to decrease the adhesion of the platelets and decrease the thromboembolic event. Those are, for example, cases treated with FredX, carotid ophthalmic aneurysm, before and after. This is dissecting giant pseudoaneurysm at the neck. The patient was presenting with crescendo TIAs, and this patient was treated with a FredX device. You see here, it's a high hemodynamic area because it's the carotid. That's why there's a lot of movements of the carotid. It's hyperdynamic, and I'm deploying slowly the FredX here, and you see it open, and then at the end it opens up completely. This is the run directly after the deployment. You see the stasis of contrast, and this is 6 months follow-up angiogram, complete reconstruction of the vessel. And this is what I showed you earlier. Another case, this distal pericallosal aneurysm. Dyna CT showing it, another superior hypophyseal. So I'm going to show you a different case here. This is a giant PCOM aneurysm. Treated this with FredX assisted coiling. In large aneurysms, I like to coil in association. And here we're doing the tour of the word in the aneurysm. Then we need to reduce the loop inside the aneurysm. In this case, I used a stent reaver to anchor distally, reduce the loop, then pull the stent reaver, then go up with the flow diverter. Here's my flow diverter being deployed. I already jailed a catheter in the aneurysm, and then I'm associating the flow diversion with coiling. This is the stasis of contrast after. And this is an interesting dissecting A1, A2 aneurysm on a young patient. So what are the open surgical options here? We can do a A2 side-to-side bypass and shut down the vessel, or here I decided to reconstruct it with a FredX Junior. So you see here, I'm deploying it in the vessel, and the FredX Junior is a 21 microcatheter. So you see here the Dyna CT. You see all the Dyna CTs, how we were able to cover it. And this is on the right side, the 6 months follow-up angiogram. You see a complete reconstruction of the vessel. You see it here. This vessel that used to look so diseased is completely reconstructed. Surpass, another flow diverter with more braids than pipeline, more wires, and FredX. Also, this is a giant aneurysm that I'm treating with Surpass. You see here the Surpass is herniating in the aneurysm. In this case, I decided to use another technique where I would have deploy the Evolve or Surpass. Used to be Surpass, now it's called Evolve. And then once it catches the wall, I would pull, and then I would reduce the loop in the aneurysm. So you see here, I'm pulling, I'm pulling because I'm half deployed there. I'm grabbed at the wall, and then I'm reducing this loop, and now I can continue and then deploy my flow diverter. Other cases, recurrence of a PCOM treated with the Evolve, and you see a 6 month follow-up angiogram, complete occlusion. Another carotid ophthalmic aneurysm treated with the Evolve. Being deployed. This is the last third of the flow diverter that's being deployed, putting some forward pressure to open it. And here it is, it's open. And you see here the Evolve, and you see my microcatheter, and I'm associating this with some coils. Whenever there are intradural aneurysms above 10 millimeter, I like to associate with some coils to enhance the thrombosis of the aneurysm. A pipeline, as you know, it started with pipeline, then pipeline flex, then pipeline shield, and now the most recent is the pipeline vantage. The pipeline shield has a surface modification, the phosphorylcholine, which will decrease also the thromboembolic events, supposedly decreasing the adhesions of the platelets on it. The pipeline vantage is a more wire than the pipeline, and the difference is you have bigger sizes up to 6 millimeter in diameter, and you have length up to 50 of length. So it's much bigger and longer. And the pipelines that are 3.5 and smaller, you can deliver them through a 21 microcatheter instead of a 27 microcatheter. This is the phosphorylcholine coating. And this is, for example, a P1, P2 aneurysm treated with pipeline, complete reconstruction of the vessel, distal pica aneurysm treated. This is an MCA aneurysm that was clipped long time ago and wrapped and came in with a recurrence, dominant hemisphere. Again, doing a redo surgery here. It can be done, but it is associated with high risk of injuring the dominant hemisphere. In this case, I decided to use flow diversion. I'm not saying that every MCA aneurysm needs to be treated with a flow diversion, but when you don't have any better option, this would be a good option. And you see the 6 month follow-up angiogram, complete reconstruction of the bifurcation. Another ballooning of the M1. In this case, what are our surgical options? We can do a deconstructive procedure and a bypass. In this case, decided to use a pipeline with some coils, and you see here the 6 months follow-up angiogram. A ruptured aneurysm, posterior fossa, you see here a blister dissecting mid-basilar aneurysm. And in this location, I think doing an open surgery would be really a high risk, especially in a ruptured aneurysm. And I don't think a better result we could have gotten a better result if we had used a different technique. You see, I used the pipeline, and the vessel is completely reconstructed. This is a young patient with this partially thrombosed aneurysm. You see the whole M1 is ballooned up. Again, this is a case where I did telescoping FredX. You see this dysplastic aneurysm, and lateral view. And this is the construct that we did. You see those are 4 telescoping FredX 5.5 by 32, jailed a catheter, put some coils. And this is the immediate injection after. And this is a 6 month follow-up angiogram, reconstruction of the vessel, and the patient is doing very well. Again, before flow diversion, we weren't able to treat those aneurysms endovascularly, really. And then we learn, and then we looked, we look at our cases, and we try to find predictors of good outcome, predictors of occlusion, of bad outcome, and this is we looked recently at our series of 598 pipeline aneurysm treated with pipeline, and we looked at association with delayed aneurysm rupture, for example. It was a previous history of subarachnoid hemorrhage, posterior circulation, increased aneurysm size above 25 millimeter. Those are all associated with delayed aneurysm rupture. Distal intraparenchymal hemorrhage. This is associated with baseline P2Y12 if it's 2 inhibited, and then increased number of pipeline used. And then associated with unfavorable outcome and morbidity, all those factors there. So it's very important, really, when you start using a new technique to look back and see and try to associate, have predictors of good outcome, predictors of bad outcome, to be able to do to select the best patient, because the best most important thing is to marry the correct patient with the correct device, right? Putting a pipeline technically is not difficult, you can do it, but the problem is you shouldn't do it on everyone, and you should really screen and choose the patient to use the device on. Intrasaccular devices, another flow disruption, that's been used a lot the last 5 years. This is the web device. It's like a cage. There are two different shapes, the SL and the SLS. That's a little bit circular, and those are the sizes. And those they go through from a 17 microcatheter up to a 33 microcatheter. This is a subarachnoid hemorrhage patient with this ACOM aneurysm rupture. If you look at it, actually, it looks like a peep, an Easter peep. And this was treated with a web device. It's especially interesting in ruptured aneurysm because those aneurysms otherwise would have gone to the OR for a clip. Otherwise, you would have needed a stent to treat them. And in subarachnoid hemorrhages, we try to avoid stent-assisted coiling because of the intrication and challenge of the dual antiplatelet therapy. This is the device here. It needs to be oversized and compressed. And this is the follow-up complete occlusion. And this is what you see in general, the stasis waving of contrast inside the web device. Same thing here. And you see in the web device, the follow-up angiogram, MCA aneurysm before and after, 3D before and after, large MCA aneurysm before and after with the web device, a small basilar tip aneurysms treated, another basilar tip, an M2. This is the most recent case on an old patient. Look at this large basilar tip aneurysm, and here it is after the web device. And sizing is key. This is from our first paper we've published after FDA approval. We're showing here how it's really important if you take the B and the A. Initially, we used to say go 1 millimeter above. Now, I would say go as much as you can oversize, but you need to take away the length from it. So if you oversize by 2, you need to make sure that you're oversizing too much. It's going to elongate, so you need to shorten by that much. And this is the technique called corking the neck, where it doesn't matter the size of the rest of the aneurysm. As long as you can cork the neck with a web, you just go ahead and do it. This is from our paper on ruptured. Web is really great for ruptured aneurysms, and we didn't have any re-ruptures after in the series where aneurysms were treated with web. And then you can follow it with MRAs. You see here, it's nice. It doesn't give any artifacts following the ACOM aneurysm. Now, like any new devices, people were saying, well, and what happens if there's a recurrence? There's no way to know how to treat the recurrence. Well, yeah, there is a way. And this is, we published this paper where we looked at retreatment strategies. And it depends on the recurrence. You can treat it in different ways. It can be from putting stent-assisted coiling or putting more coils or even clipping. This was the first web that was clipped. And it's actually easy. You can go in and clip the web, and you would crush the web and clip it, as opposed to coiling, where sometimes it's tough to go and clip a previously coiled aneurysm. This is in our occlusion. Adequate occlusion was like the Webbed trial, 86.6% with 5.5% retreatment rate. Predictors of aneurysm occlusion, we talked about that. And let's move to another intrasaccular device, which is called the Trenza device or Citadel. And this is for the first time, it's first in human in the US. As you know, usually everything starts with CE approval and then comes to the US. But this is a device or a coil that's used like an intrasaccular device, and the trial is being done as first in human. So this is like a wide leaflet coil that you use for wide neck aneurysm, that you would go and deploy it to cover the neck. And then after that, you start putting regular coils. It's called the Trenza device, and it's in a trial. So this is the Trenza device. You see like wide wide leaflet of coils. It's a little bit like the Medina, which was really wider leaflets. This is an aneurysm recurrence after clip that I used this device on. This is another ICA bifurcation aneurysm that was treated with the Trenza. So this is the Trenza first deployed, and then you go in and continue coiling the aneurysm. But in those cases, you didn't need stent, Y stenting or stent or balloon, because the first device, the Trenza, really gave you the frame where your coils will stay. What I was talking about earlier is the Medina. That's the Medina coils. I guess it doesn't exist in the US, or it's they didn't release it. This was Medtronic bought this long time ago, but they still didn't do anything to it. It was like a flow diverter, but intrasaccular. Move to the contour device. It's exactly as I'm showing in this picture. I thought this was the simplest way to show you how it works. So it's like a funnel shape, and the main goal is to deploy it at the neck of the aneurysm. You don't worry about the rest of the aneurysm. You don't worry about sizing it, but all you do is plugging the neck. Uh, the trial is going on in the US now. I'm the national PI for it, and we're at the end of the trial. We still need to enroll 20 patients and we'll be done. And this is the device in vitro. You see here, it's getting deployed. And then you see the contrast here being injected, how there's waving of contrast and stasis inside the aneurysm. You see here in a tube, it's being deployed. And that's the shape that you would like to see. And you need to pull and push, make sure that it is stable. Those are the different steps. And see, we're giving a push and a pull to make sure it's stable before deploying. And if you look at the physics and the vector forces, for example, the vector forces is in a way where the blood flow would go and be split by this device hanging down. And as you see here, like the Concorde airplane. This is an MCA aneurysm that I treated transradial with a contour device. You see here the aneurysm, and then that's the contour device. And then I'm unsheathing it at the neck. So it's very simple to size. There are 5 sizes only. You size it at the neck. You see immediate thrombosis and of the aneurysm here. And then this is the expert CT showing the device, showing the stasis of contrast. That's after deployment. And And this is the follow-up angiogram, 6 months follow-up showing complete occlusion of the aneurysm. Some other aneurysms treated with the contour. This is a ruptured aneurysm, ruptured ACOM that I treated, 6 months follow-up. This is a basilar tip. You see how we deployed it and it really kept those small PCAs open. You see here before and after, ACOM, basilar tip, even very shallow basilar tip showing that. Another shallow basilar tip. And not only devices, but the launching pad. This is really interesting. This is the banded microcatheter. We never had in neuroendovascular a steerable microcatheter. So now the steerable technology is coming, and it's the future. Steerable microcatheter, steerable microwires. This is the device of Dr. Alejandro Berenstein, and you saw his picture earlier with me. And practically you can torque it and steer it and bend it from proximally, and it will help you go in and advance it. Here, I'm not even using a wire, I'm using the device, not a Terumo wire. I'm using the microcatheter. And you see here, I'm advancing it without the wire. So you can flip, advance, and here it is, you see it now in the aneurysm. And then I deployed a contour through it. And this is the follow-up angiogram of the contour. This was a recurring anterior temporal artery aneurysm that I treated with contour. The Artis device, it just got brought back, and there's a trial that's gonna start soon in the US. It's being used in Europe, and it looks like a web. It's a little bit softer. It takes the shape of the aneurysm much more softer than a web, but I don't have any experience with RTs, but we're gonna start the trial soon. Another intersaccular device, the seal device, it's a device that combines an intersaccular device and the flow diverter. If you look here, and there are different shapes. Those are the three shapes for shallow aneurysms and for deep elongated aneurysms. And those are the sizes. So there are two shapes, I mean, and those are the sizes. And there's actually in Colombia, my friend Boris Pabon has done many cases with good results. So those are some cases of his. This is courtesy of Dr. Boris Pabon. This is an MCA aneurysm before and after, another aneurysm treated with the seal arc device. Adjunct tools, as you know, this is the Comenici device. It's a temporary stent. It's a little bit like a stent retriever, but as you see here, you can make it open, inflate it like a balloon and deflate it. And this, the idea is for wide neck aneurysm, try to use it to coil and then remove it so you won't commit the patient for dual antiplatelet therapy. This is a case of A2 aneurysm, wide neck. You see the wide neck. If we didn't use this, we would have used either balloon assisted or stent assisted. And you see the device, the Comenici here. And coiling, that's the Comenici device that's inflated. And continue coiling. And this is the 6 months follow-up angiogram, complete occlusion. Now, I've showed you a lot of devices, but you shouldn't be confused what device to use, especially in some circumstances like that. Right here, there's no hesitation what to do. We don't even have the time to do an angiogram. This patient goes from CTA directly to the OR. When an aneurysm presents with an intraparenchymal hemorrhage, you need to go in, decompress the patient, and just clip the aneurysm. And this is a case where the patient had a MCA aneurysm with an intraparenchymal hemorrhage. You see here that's my temporary clip, and then that's my permanent clip, and this is another clip, and intra-op angiogram, and you see the decompression. Another intraparenchymal hemorrhage with a large PCOM aneurysm, same thing here. There should be no hesitation in your head. You take the patient directly to the operating room, decompression, evacuate the subdural hematoma, and go clip the PCOM aneurysm. Here you see my temporary clip on the ICA, and then here it is. I'm going in and clipping the PCOM. That's the intra-op angiogram. We always do intra-op angiogram showing 100% occlusion, and then the decompression is here. But at the same time, no dogma, right? So this is a patient with an intraparenchymal hemorrhage. The patient was awake. The ventricle didn't show high ICPs. In this case, we have time to go in. We did an angiogram. The patient had a pericallosal aneurysm. I thought I could coil it. Why not? I coiled it. And then I knew that this patient in 2 days, they're going to call me at 2 a.m. to decompress because of swelling. So we coiled the aneurysm, good result, and then took the patient to the operating room for a decompression. And, sorry, here it is, yeah. And we decompressed the patient. Other case of mass effect, this is a giant ICA bifurcation partially thrombosed aneurysm. Those aneurysms exert mass effects. It's like tumors. Actually, somebody saw this patient as an outpatient and they were talking about possibly being a tumor. Luckily, no one tried a stereotactic biopsy. They would have had a unpleasant surprise. So actually, this patient has this ICA bifurcation aneurysm, but what you're seeing here is the tip of the iceberg, right? That's only the filling part of it. The aneurysm is much larger. It's a giant, but it's all full of thrombus. In this case, we need to go in, open the aneurysm, open the dome, and evacuate the clot, and to be able to flatten, soften the aneurysm to be able to clip reconstruct it. So you see here, I'm dissecting the inflow, outflow. So ICA, MCA, A1, that's the aneurysm here. I need to get access to be able to trap the aneurysm. And here I need to start, here I'm trapping the aneurysm, and then I need to start by opening the dome of the aneurysm and evacuating the thrombus to be able to, you know, clip the aneurysm. Otherwise, you cannot clip it. It's hard like a rock. So here I'm using the CUSA, the ultrasonic aspiration, and I'm opening the dome of the aneurysm. And I'm not trapped right now. I'm gonna keep on working because we don't want to have any ischemia time. But I'm ready to trap whenever I need it because I know that I'm gonna start evacuating thrombus at a point, I'm gonna have some bleeding because I'm gonna hit the true lumen. At that time, I know where my ICA, MCA, ACA are. I have temporary clips ready. I can go in and trap the aneurysm. And starting at that time, I'll start working 5 minutes on, 5 minutes off to reperfuse the brain. So here, I'm evacuating this white thrombus, organized chronic thrombus. And here I'm getting closer. You see it's becoming red. And now I'm going to get ready for some bleeding. Here it is. But I wasn't surprised because I was ready for that and I knew what to do. And then I'm trapping the aneurysm, trapped it, and then I'm gonna keep on working. 5 minutes on, I remove a thrombus, and then 5 minutes off, where I would place big clips on the hole I made to be able to remove the temporary clips to be able to reperfuse the brain. So we could keep on doing this on and off until the aneurysm is soft and I'm able to put clips on it. And then at the end, you're gonna see completely clipped with an intra-op angiogram, those large clips that I used, and that's the patient. Another giant aneurysm, another technique. So here you see the L2s coming off the aneurysm. In this case, you need to go being ready, save the STA, being ready for a possible bypass. But the way you're going to do this is this aneurysm doesn't have thrombus in it. So I can trap it and use the suction decompression technique, where I would trap the aneurysm. I would take a spinal needle, hook it to suction, and poke the aneurysm, and it will flatten, it will suction it. I'm able to dissect and find my M2s. So this is my spinal needle hooked to suction. And you see here, this aneurysm I'm able to dissect, and I'm able to find my M2s and decide if I'm able to reconstruct it or not. And here it is, I'm reconstructing the aneurysm, keeping the M2s open. This is the intraop angiogram. Those are the clips. Sometimes they are prominent. And sometimes when the clips do not fit, what should we do? In this case, what we did, we drilled a hole in the bone for the clips to come out and then put a titanium mesh to protect it. And then it's very important to try to listen to your devices. Again, I'm showing you a lot of devices, but this is a two-way conversation. You need to remember what does listen to the device mean? Means, remember the cases where it worked, remember the cases where it didn't work, see how the device is behaving to be able to adjust your practice and get the better outcome. And then try to learn from your mistakes when you're using those devices. A lot of times we end up doing exactly what this sheep is about to do, right? And here it is jumping again, doing the same thing. And we all have done this and kept on doing the same thing. And then don't be judgmental and jump quickly to conclusions. Stay open-minded because this is not what you're thinking about. This is actually what's happening. And be ready with the new devices. They're going to have new problems that we never encountered before because those are, new devices. And practically, it's a match between you and the device. It's like dating. It's like a dating app, like Match.com. You and your device, and you and your new technology, you get to know each other exactly like your date. You get to anticipate the reaction to your action. You get to learn to avoid embarrassing situations. You get to know how much to ask and what to expect from your device, exactly from your partner, and then avoid pushing to a nervous breakdown. Remember, some wounds are not repairable. And this is all I wanted to tell you this morning. Thank you.
Thank you very much, sir, for this very elaborate, eloquent lecture. It was so informative, so interesting. And again, thank you very much for sparing time from your very busy schedule today. Sir, since you've been considered one of the, forefronts in robotic introduction of robots in neuro intervention. Sir, I really have this personal, this a personal interest in asking you, what do you think about the robotic assistance in
Yeah. Yeah.
neurointervention for aneurysms?
Yeah. So in general, we were one of the first to jump on the robotic technology. We were very excited about it because we saw that it may be something for the future. It may be a prelude for remote stroke intervention, maybe in those patients living in a remote geographic location. The first version of the robot, which is the Corendus robot, which later on got bought by Siemens, unfortunately, in the US, it wasn't FDA approved for any intracranial yet. It was for peripheral, so we were able to do carotid stents and angiograms with it. But in Canada, Vitor Pereira did a lot of intracranial aneurysms, had great results, was able to demonstrate that it's really very accurate when you decide to deploy a stent. The landing zone would be really accurate. When you twist a microcatheter, it will do it much better than manual. And we were very excited about the robot, about the future of how we're going to use it. But then what happened is Siemens decided to take all their R&D force and to focus on the new generation robot. So the robot program got stopped. They removed all the robots, and now they are working on the next generation robot, which can do so many things. I visited them. I saw the robot. I tried it. It's really, really amazing, and it's gonna be really the future. And it's gonna be released hopefully in a year to a year and a half with a trial. But this thing is amazing. You're able to do so many channels. You may able to work intracranially, and this really would be definitely the prelude for remote stroke intervention for that. So stay tuned. The coming 5 years, you're gonna see exciting stuff.
That's really great and really futuristic, sir. Sir, there is also this recent growing interest in magnetically navigated micro robots. So, what do you think about those?
Yeah, so I saw the technology actually. It's a group from Europe, from Switzerland that are using it, where practically you're able to navigate by using like a small magnet outside the patient. You're able to attract the catheter. And in cardiology, they had this long time ago, but now they are developing it for neuro. It's still, in a trial. It's not in human yet, but it's very promising. And imagine if you're able to attract the tip, regardless of the tortuosity or anything, you're able to take it and attract it and bring it to where you want to bring it. This is really, I mean, in the pipeline, there's a lot of exciting stuff coming. So it's a good time to be in endovascular.
Yes, exactly. But sir, one has to be so much versatile, so much have impeccable expertise like you in both open surgery as well as endovascular surgery, both for decision making and both for for conversion if required. And I think this is very it's not like an easy task for everyone to do. So, sir, there is also one concern. Just one final question. I believe you are so much busy. Just I'm not wish to take more of your time.
No,
Sir,
no.
there's one final question. Thank you very much, sir. Sir, regarding the haptic feedback, because there is also a concern regarding the haptic
Yes,
feedback in
yes,
robotics. Yes.
yeah. So those are one of the challenges of remote intervention, and it's haptic feedback. Now, again, if you think about it, we neurointerventionists, we used a lot to our vision also. So haptic feedback is important, but vision is also important, right? I mean, we train fellows, and a lot of times, just from what I'm seeing, I say, stop, let me take over. So there are a lot of signs that you can see with this. But talking about the haptic feedback with with the new robot, you can really measure it at the very minimal increase of pressure, where if it senses at any tip of the microcatheter or microwire senses a very small increase of pressure, it will stop. Even if you're still advancing it, it will stop it right away. So this is, and this is difficult. It's like machine learning. First, you need to get so many surgeons and try to blindly tell them how much pressure do you tolerate, and then they need to get from all those physicians to translate this to the robot to decide what's the pressure measurement that the robot will detect for it to stop and not let you advance it. So there are a lot of things that can be done for that, but the haptic feedback, I agree, is important.
Thank you very, very much, sir. Thank you again so much for your very wonderful lecture and very elaborate. You have given a lot of things to think about and have a very eloquent account of everything that you have very nicely mentioned, sir. Everyone is sending you special wishes and best regards, and everyone is so much impressed with all the things that you have shared so far. So thank you very, very, very much, sir. Especially again, I would like to thank you for spending your time. So I hope, sir, I really wish to have the privilege of inviting you once again and to have this honor of listening to more of your lecture and to learning more from your wonderful cases, sir.
Well, thank you so much, Maria. It's a pleasure and honor, and thank you for having me.
Thank you very, very much, sir. The pleasure and honor is all ours, and I think it's a huge privilege for all of us to have this opportunity of listening to masters like you. And when I started my own residency back in it was in 2015. So back then, we would read about people like you, legendary people like you in the journals, in our books, and we never have thought that we could have this privilege of actually
Thank you.
learning from you virtually, but it's a huge privilege. So again, I really wish to like thank you. Thank you is a very small word for what teachers like you are doing for everyone around the globe. Which means a lot to all of us, and it's making a lot of difference positively. So
Thank
thank you very, very
thank you
much,
so
sir.
much, and keep up the good work you're doing. I think you're doing a fantastic, amazing job. Really, congrats.
Thank you so much, sir. It means so much to me. Your encouragement is what keeps me going. Thank you very, very much, sir. It means a lot.
Okay, great. Thanks. Okay, bye.
Nice. Have a nice day, sir. Thank you very much, sir. Thank you all for being here. I'm going to share the link to to the Google form, so you can just submit it and get your certificate. And I'm also going to share, uh, you know, just a moment. I'm sharing the link to the form, Google form, so you can just submit the form. Again, I want to tell you that all the quizzes are non-graded, so you don't have to score, some certain score to gain to receive your um, certificate of attention. Thank you very much, Dr. Yuza Arif. Thank you very much for wonderful words. Thank you very much for your amazing remarks and everything. Thank you very much, Dr. Faiz. Thank you very much, Dr. Saima. So much. It's so great to see you here. Dr. Saima is one of the very, eminent in my, especially in my city in Lahore. She's the only female neuro internationalist. It's an honor to have learned from her and to welcome her here. Thank you very much, Dr. Saima, for being here. You are an inspiration for all of us. And again, okay, so this is the Google link to the quiz. Just submit the quiz and receive your certificate right in your inbox. And here is okay. I'm going to now announce the first project for the news members. So let me share my screen. Just a moment. Actually, like I have mentioned that I'm supposed to announce the first project for the news members. I have also shared, my membership information. It's free, and all you have to do is to, submit a form, and you will be given a membership certificate of the submission of that particular form. It's very easy. It's for you to do so. Let me share the screen. Okay, so here it is. You can see that. Let me start a screen share. Okay, so this is the news member only project. So this is the project number one. I'm going to, announce this project for the news MCQ pool of neurosurgery. Okay, I've been, many of my wonderful colleagues, my juniors, and some of even seniors who are not quite senior, but many of them were so much interested in having a neurosurgery MCQ poll. And for the juniors, it's especially important for preparation, exam preparations. So again, I wish to. This is the first project. Again, it is totally free of cost to create this MCQ poll, and we might consider launching it in the form of a book, but we can have it for free, available for free on the internet, and also in the form of book, because many people really wish to have a book form too, so that they can keep it with them, and just carry it everywhere. Like I remember when we were residents, we also had books in our bag so that we can have the privilege of reading it every time, anytime, if we have any free time, so that we can just keep on learning. So this is the first project for the news members. This is the creation of the news MCQ poll of neurosurgery. The plan here is I will be sharing a spreadsheet with all of the members who have just recently joined, like who have joined formally through the submission of the form. All you have to do is to write your name, and whether you are a trainee or you have completed your training, and also where are you from. And this is how we will create a list of others, which is very important. And this is how we are going to, it's an honor to, flaunt all the wonderful others who have contributed to the creation of the MCQ tool. So I will first rotate spreadsheet. It's not mandatory for all of you to contribute in the formation of MCQs, but I strongly recommend you all to send as few or as many MCQs as possible. If you have just only a couple of MCQs, please feel free to contribute as well. Okay, so because the goal here is to promote more neurosurgeons in contributing towards neurosurgical education, toward the promotion of neurosurgical education and training, and encouraging others, and also training each other in this process. So just have this thing in your mind. Even a little contribution will be really appreciated. Okay. So first of all, I will send you this. I will email you the spreadsheet, and I will also tell you the sections, the table of content that we will have. Every other, can select more than one section. And if there are more others who are interested in the same section, it's also fine, because it's a poll and everyone is a contributor. So if you are interested in more than one section, you are welcome to do so. If one author is interested in the same section, it's totally fine. And all we need is to pull as many MCQs as we can, as we possibly can. If you have cases, interesting cases, please feel free to share them as well. And after that, once we have the list of authors and we have the sections ready, then we will have an online training class in which we will demonstrate how to create MCQs. Okay, so whatever we can do to train you. And if you have any questions, or if you have any, like you are having some sort of, issue creating an MCQ, just feel free to discuss it. It will be an interactive class, and everyone will be free to ask questions and to learn as much as possible. Again, this is a totally free activity, and it's just the only focus that I have, or anyone has, is to promote more training and more education, and to have everyone at the same platform from all over the world. So contribute as many as possible, and or as few as possible. Like I have said, if you have only just a couple of questions, please feel free to share. And again, it is good if you already have experience, but if you do not have any previous experience, remember, nobody is perfect when he or she starts doing something he or she has never done before. And I will guide you as much as possible at every step, and will make necessary corrections, as the goal is to encourage each other and to train each other. Everything is introduced and organized by news is free, like always. So this is the project, and I'm so much looking forward to have you on board. Please feel free to submit your things, your submissions, your MCQs and everything. And also, I'm looking forward to receiving your submissions for the news blogs, as well as the newsletter. So please feel free to send your submissions on the email address I have shared in my chat box. Please feel free to share your submissions for the newsletter and for the news blogs. And also, please stay tuned for the first project, for the first members only project, which I hope you will all like. I will shortly be sharing all the stuff that I have talked about with all of you. So again, thank you very much for being here today. It was wonderful to be with you all and to learn and train each from and learn from each other and to train each other. I think it is the main goal of news. And looking forward to seeing you again in the next webinar. And thank you very much, Dr. Isamul Haj. I think that I really wish that we should do something. All of the members, all of the news regular attendees should do something together as a team because it's one neurosurgery, like Professor Asama Mufti always says, one neurosurgery, one world. So I believe that. Okay, no problem. You can always go to my YouTube channel and see the recording. So if you have missed it, no worries. It's available on my YouTube channel. And please subscribe to my YouTube channel so that you can actually see as many videos as uh, possible. I'm now sharing the address of my YouTube channel. Please subscribe to my YouTube channel. No, there is no criteria for the MCQs. Okay. I will just try to submit as many as possible. If there's any modification which is required, then we will discuss it later. Like I've said, do not hesitate to send whatever you have made. It's just a simple MCQ formation. If there's any correction or modification required, we will discuss it. And we will also have this unit director workshop on MCQs soon once we complete the order list. So I believe that will be fine. Okay, so this is my YouTube channel. Please feel free to subscribe to my YouTube channel, and you can access all those recordings. The feedback link. Okay, I guess I have already shared it above. If you are here, um, here's the feedback link and also the membership link, which I've already shared above. Please, if you don't have it. And this one is for the medical student. The next one I'm sharing. Thank you very, very much again. And I'm looking forward to um, uh, welcome, Dr. Famida Malai. So good to see you here in the webinar. Dr. Famida Malai is also a female neurosurgeon from Pakistan and the current chair of the Women's Pakistan section. So good to see you, meet you here virtually. Welcome to the webinar. So again, everyone, thank you very much for joining. We will stay connected through my, the news web page, the news Facebook page, and the WhatsApp groups. And looking forward to all the submissions and to all the new memberships. And I will be keep updating you and mailing you. Thank you very much, Dr. Hamida. Thank you so much, everyone. So see you all soon in the next webinar and in the training workshop. And have a wonderful rest of the day. Bye bye.